Hi, my name is Brandy Butcher, and I am doing activity 2 for SIM 440 for American Sentinel University. Activity 2 is chronic disease management. So the disease that I chose was COPD, which stands for chronic obstructive pulmonary disorder or disease. According to the CDC, it is the 4th leading cause of death in the United States in 2018. I read some other things that says it is now up to the 3rd leading cause of death. The current population in which this affects is women. It actually says that it is more of a women disease than men disease, which I feel like when you think of COPD, you think of a man, but it says that it actually affects way more women than men. People between the ages of 65 and 74 and greater than 75. American Indians and Alaska natives. People who were unemployed, retired, or unable to work. People with less than a high school education. People who are divorced, widowed, or separated, current or former smokers, and people with history of asthma. So this is just a few of the people that it affects. Obviously, you'll have some outliers that may not fall in these groups and can have it. I will discuss how to evaluate for the population, assess potential benefits, analyze our goal, identify other team members that should be included in the care of these patients. So COPD plays a big role in the hospital admissions. I think that's how you need to evaluate it if patients get admitted or even just come to the hospital for shortness of breath, for difficulty breathing, like chronic cough, things like that. Those can be indications that there is an underlying lung condition. And then I feel like further testing could be done, or if they already have a diagnosis of COPD, those are the ones that you need to evaluate and come up with a plan on how to reduce hospital admissions and to manage their illness better. This population already has a decreased lung capacity, so it makes them more susceptible to other illnesses, and then it can cause further exacerbation of their COPD. These patients are usually very fearful because they can't breathe and they always feel like they're can't catch their breath and they're afraid they're going to die, and they need some extra attention and teaching just to kind of help manage not only their illness but their anxiety and their level of compliance. So to assess, I feel like there should be a formal case management program for this population because they have such a high readmission rate. According to the NCBI, within 5 years of a hospital discharge for COPD exacerbation, the readmission risk is 44% and the mortality rate is 55%. That being said, anytime a patient gets admitted for the same thing within a 30-day period, Medicare and Medicaid are no longer wanting to pay for this because they feel that we should have been able to better treat them, or we should have been able to do better teaching and to help them to not have such a close hospital admission or hospital reoccurring ER visits. Potential benefits, being followed by case management could lead to more compliance and less hospital stays. Case management could ensure that the patient has a primary care doctor and has any equipment they need. Sometimes COPD patients need nebulizers, oxygen at home, and then you have things that aren't even necessarily related to their lungs, but patients that have COPD get fatigued easy, so they may not be able to walk long distances. So just help with getting walkers or having different things set up in their home, like handrails and things like that to help them get around. Also would be good. And then outside resources such as home health or hospice services. These would give the patient more options to stay out of the hospital and be able to be treated on an outpatient basis. So as far as analyzing all of this, I used to work for a hospice, and they had a COPD program. So to be on hospice, you don't have to be, I don't know if it's the same everywhere, but where I am from, you don't have to be a DNR. You can be a full code and be on hospice. But their COPD program was very unique and helped a lot of people. So they had where the patient would receive a nurse visit every week. If they qualified, they would also be able to receive aid services. So somebody to come in, help them bathe, help them make sure they ate, and just, their daily living things that they need extra help with. They also had access to on-call nurses and aides 24 hours a day, 7 days a week. So with that being said, that they kept a emergency lockbox in the patient's home that had multiple medications to help. If a patient was having a COPD exacerbation, they had Terbutaline, they had Lasix, they had Haldol, some more anti-anxiety meds. So if you were to get called out in the middle of the night or after hours, you would follow the direction of the on-call doctor. So you would call, you would evaluate the patients and tell them what's going on. And then if the on-call doctor says that you should give something in that box, then you would give that medicine. And then you would stay until you could, safely say that this patient is okay and that you can go. A lot of times that would help keep patients out of the hospital, and they wouldn't need to go because these medications help treat them at home. If this box was had to be used, then the following day they would receive a actual physician visit. Now we used a lot of we have a service of doctors that come to the house, and then our actual director doctors through hospice will come and visit as well. So many times we were able to correct the issues at home, and these patients would never have to leave, and they did well with that. As far as identifying other team members, I think that other than case management, the primary care physician, the primary RN that's taking care of the patient, and the family members all need to be involved in the patient's care. The nurse will be responsible for doing discharge teaching, so they definitely need to make sure that they are able to clearly tell the patient what's going on, what kind of symptoms to watch for, what things they can do to prevent having a COPD exacerbation, and just overall general things that they can teach on to help them to lead a healthier lifestyle. The primary care doctor will be doing regular office visits to maintain the patient's overall health, as well as any medication regimens that they may need to be on. The patient also needs to be involved in their care because they need to take responsibility for their illness and try to manage and participate in their care and be able to take some direction into how they want, their overall care to go. And then the family, because patients always seem to do better if they have a stronger support system. With COPD, eventually, usually all patients get to the point where they can barely do anything because even short distances or short amount of activity causes them to not be able to breathe. Their lung capacity just continues to diminish throughout that entire illness. So if you have a strong support system, obviously it's going to make the disease a little bit easier to cope with and be able to manage. I do know some patients don't have any support whatsoever, and that's why I think that hospice and then, of course, case management could help to set them up with somebody that could at least give them a little bit of guidance and little bit of extra help on an outpatient basis, so they wouldn't have to stay in the hospital or a rehab facility. COPD is a tough illness, and it is a long battle, and it's hard to see these patients, fight for so long. But it can be managed, and they can live a fairly good quality life for a while. So, with that being said, I appreciate your time. Thank you so much.